estimated that there are favorable government activities which may improve the situation, not because the situation currently was good in 2015. Now, the problems pointed out were mainly two. One, we do not relieve pain and suffering. Relief from pain, basic pain, reaches less than 2% of the needy in our country. So people in excruciating pain and agony and other suffering were dying without relief from them. And concurrently, there is this paradox that a lot of people die a worse death if they have money in the pocket because they receive inappropriate, aggressive end-of-life care. Now, I am an intensivist of the past, and I know from experience that the time in an intensive care unit is a time of extreme agony, both physically and emotionally and financially. Physically, because you are confined to a bed, and very often happens in Indian intensive care units. I mean, I'm sure some people will say we don't do it. Physical restraint is the order of the day. Certainly there are exceptions. I said by and large. Second, the breathing tube is one of the most sensitive parts of one's body. And that's where we are poking in the endotracheal tube, and a suction catheter is going in and getting twisted as it is withdrawn. I have talked to people. A doctor who experienced an endotracheal suction and a conscious presence of an endotracheal tube just for a minute said that that was the worst experience in his life. And again, a young man who needed ventilation for a few days said, till he got pain relief, he was unable to think. And the moment he sees a nurse's uniform, because he, in his muddled brain at that time, associated the nurse's uniform with the suction catheter. And he broke into uncontrollable panic. Though he was restrained, he tried to fight it. So, because we do not treat pain and suffering, and because people, even with conditions like advanced cancer or dementia or advanced Parkinsonism, are still subjected to aggressive end-of-life care, our suffering at the end of life is considered among the worst in the world. I will certainly expect to have a lot of questions and discussion about this at the end, but right now I am moving on. And we all know that this is how health is defined: physical, mental, and social well-being, and not merely the absence of disease or infirmity. Many of you are very experienced clinicians, and I believe that it would be a good exercise, even for the experienced clinician, to sit down this evening and contemplate if you agree with that when it's a question of your own health. Are you looking for only treatment of disease, or when would you consider yourself healthy if you have well-being? And the second question that arises is, do we not have a responsibility to provide this true health? No, it's not achievable. Very often the challenge is almost everybody who reads the definition immediately responds to say, complete well-being is not attainable. So please let us not concentrate on the word complete. I am just suggesting that you and I as healthcare providers have the fundamental responsibility to aim for the best of well-being and not only treatment of the disease entity. In the case of COVID, again, like any other disease, including your patient with Parkinsonism or dementia or advanced cancer, we would still like to have well-being. And when we talk about social well-being, in the Indian context, let us also think of the financial suffering. I don't know how many of you have come across it, but in 2018, a paper published in British Medical Journal is by 3 Indian authors estimates that in a single year, 55 million Indians, more than 4% of our population, are pushed below poverty line by catastrophic health expenditure. And this trend is growing, and World Bank data show that India and Bangladesh are among the worst 12 countries in the whole world where this destruction is worst. And as you all know, the number of families destroyed by inappropriate, aggressive life support at the end of life is huge in this country. Raju, next please. Now that was the background in which I want to bring up with you the relevance of palliative care in COVID-19. In 2012, WHO defines palliative care. This is not the full definition, but the crux of it is it's aimed at improving quality of life of a patient with life-threatening disease and the family. And everyone in this group who has gone through the experience of a serious illness in a loved one in your own family would agree with me warmly that it is not only the patient who is suffering, and sometimes the suffering in the family member can be even worse, maybe as in an advanced dementia. Now, my only comment that I'll make on this is that when we talk about life-threatening life, let us not talk about life only in terms of longevity. What is life? Life is something that involves that existence with some enjoyment and some meaning. What I mean is, if we have a person with paraplegia confined to the bed for years or decades on end, I would say that he or she has a life-threatening illness because that person's life is challenged by 4 walls. Okay, that I just wanted to say that in explanation. Unfortunately, that definition is 18 years old, maybe a bit outdated. And 2 years back, 1.5 years back, a Lancet Commission on global access to pain relief and palliative care brought up the word serious health-related suffering. Anybody with a serious health-related suffering should have palliative care. And that is, they are emphatic to say that is not only in chronic diseases. Moira, who is in this audience and has gone to Gaza Valley, not for chronic diseases, but for the suffering, for the acute issues there, would agree with me. And those, the palliative care people who worked with Ebola crisis would know that the relevance is unbelievably huge. And we are now looking at a new disease which has the potential to cause more suffering, physical, social, including financial, emotional, and spiritual suffering than ever before. And therefore, as the World Health Assembly resolution called for in 2014, palliative care needs to be integrated into healthcare. In other words, all healthcare has to include treatment of serious health-related suffering as part of the treatment. That's, ladies and gentlemen, my very long introduction and background. Raju, will you please go on? Now, the suffering, as I said, is also for the rich, and sometimes worse for the rich. But often, the people who are suffering most do not even get to our hospitals. All the palliative care physicians here who go out into the community know that the people who need us most in India do not get to hospitals. They may go to hospitals in the early days, but as things worsen, they are stuck in their homes, in their villages, sometimes probably outside the house, and die horrible deaths, and that's reality. The elements of this suffering, as we mentioned earlier, Raju, next slide please, would be physical, like pain or breathlessness, cough, increased secretions, agitation, etc. as in COVID. The social issues, including the issues that have been brought down by lockdown and restrictions that will continue even when the lockdown is withdrawn. And the financial issues and the breaks in relationships, the issues associated with quarantine, family members no longer having the courage to look after people who are ill, the emotional issues and spiritual issues like, I wish I were dead. Why did God do this to me? Can't somebody kill me, please? These are all parts of this. And to anyone who is now asking, but what can doctors do about it? Is this achievable? I would say doctors do not have to do it alone. This is where medical social workers come in, counselors come in, and their team has to expand. Without them, we cannot deal with this suffering. Raju, next slide, please. So as I said, in 2014, the World Health Assembly asked all member countries to integrate palliative care into healthcare at all levels, primary, secondary, and tertiary, across the continuum of care, that is from the beginning and the suffering, which can be even before the diagnosis or at the time of diagnosis, to the very end. End is not necessarily with the death of the patient. It's also support for the bereavement period, support for the people at least with pathological grief who are trying to struggle and to get back to life. Next, please. In an iceberg, as you probably learned in middle school, only about how much? 1/9 or only a small part is visible. Even when we try to address the suffering and provide palliative care, very often you see only the physical problems. That is necessary and understandable. Very often we are able to do only that. In that case, let us do that. But we at least will remember that there are a lot of issues left unsolved. The issues caused by comorbidities, the lack of millions in our country today who do not get enough to eat because of the lockdown. And what happens to you when you have a headache? Don't you feel irritable? So what about this family confined to four walls, angry to the illness? The illness is not available for them to fight with. The anger explodes in mutual relationships, and you say words that cannot be taken back. And the issues of extreme loneliness. Let us at least realize that these are real problems, which is why I repeat, we doctors cannot do this alone. We will have to co-opt volunteers, social workers, counselors, anybody we can get. Next, please. And of course, we are going to face the ethical dilemma of end-of-life care. We are going to have one session dedicated to this towards the end of this week. This is an important thing. But I want you to think about it so that we'll be prepared for it. Maybe we'll talk a little bit about later in the discussion. But so far I've been talking about the challenges. Now let's come to the solutions. One of the most important things that we must learn and teach is triage. We cannot handle the COVID epidemic purely by medical approach, addressing the disease. We will need triage. Typically, globally, with the experience of the last couple of months, what is recommended that the triage team should be independent of the treating team. That somebody, maybe just a senior nurse, assisted by a social worker or a volunteer doctor, somebody, a team, is specifically assigned to triage so that they make just a decision about which patients have a better chance of success. Okay, like age is a factor. I'm not saying that a 93-year-old man should not have treatment. I'm saying that age is a negative factor along with comorbidities. The triage team makes an assessment. This group has a good chance of success. This does not. So later on, when we come across problems that today you and I are avoiding, and the government is avoiding, and the medical system at large is avoiding, at the end of April, when you are left with one ventilator and 5 patients who need ventilation, how do you choose? We might as well think about it now so that we are prepared at that time. Next, please. Now, that may look like a complicated picture, but there's a reason I am showing. And my presentation is getting to the close now. This I borrowed and adapted from a slide from Dr. Rajagopal, a palliative, an intensivist and a surgeon from Chennai. Now, very often when we talk about the ethical issues of choice of ventilators, of deciding on palliative care as an alternative, not as an addition, as an alternative to mechanical ventilation, we immediately come to the question, hey, is that legal? Is that not illegal? I mean, will the family accept it? So many issues. So I think it's good to identify issues one by one. First, let us make sure that we are clear about what our role is as a physician, as a doctor. What is the primary duty of care of a doctor? In India, duty of care is not defined by law. In Moira's country, UK, it is defined by law. Here it's not. But we have an ICMR document, which I will come to in a moment. But our duty of care is to mitigate suffering. Raju, can you go to the next one and maybe come back to this a bit later? This is what the ICMR's task force 2 years back, almost exactly 2 years back, came out with. The duty of the healthcare provider is to mitigate suffering. It is to cure sometimes, relieve often, and comfort always. There exist no exceptions to this rule. That's not my sentence. That's by the ICMR. There exist no exceptions to this rule. We have to mitigate suffering. Raju, can you go back to the last slide? I accept that my fundamental duty is to mitigate suffering. True, there may be ethical objections. There may be legal objections. I know. I may not be able to do what I want to, but I accept that this is my duty of care. This is my responsibility. Of course, we'll have to see if this is ethically right. If I am your patient, I don't know what's going to happen to me in end of April. If I am your patient with advanced COVID, you will recognize that I have a right to autonomy, decision-making capacity. I may say, I do not want to die. I'm not ready. Please put me on a ventilator. And you, the doctor, are faced with all these issues. You suspect that it will not benefit me. It may actually harm me. And it doesn't abide by the rules of distributive justice. It's unfair to a young person. So, though autonomy is the overriding principle, we will have to take all this into consideration. And one of the things I said, institutions have to now set up triage teams. Similarly, this responsibility to decide on what is ethically right and wrong in difficult context in the end of April or May should not be left to the treating physician alone. There should be ethics committees, people who are able to get together every day if necessary, maybe a 3-member committee, who will have to take on the task of taking that decision. This is ethically the best, because ethical right and wrong is not absolute. It's always confusing. We are very often in a doubt. So it shouldn't be left only to the treating doctor, who may be very clear that his duty of care is this, but this may have to be taken off his hands. The society will have to be prepared. A society which is not prepared to think about the future will not be able to accept anything. We will have to look at the economic realities. People are scrambling for ventilators, just announcing that we will have a ventilator for every citizen in the country. Is that realistic? And the legal issue is a big question mark, because India doesn't have a law covering this, and the Supreme Court judgment is confusing. There are issues. These are things we'll talk about later this week. Raju, next and next, please. I will stop there, ladies and gentlemen. We have, if I understand correctly, 24 minutes more. What I would like is your reactions to what I have said so far. Raju, we may have to go back to the presentation, so please keep it ready in case I request you to share the screen again. So I would like your reactions. I don't know whether Raju has told you this already. Anybody who wants to say something, please raise your hand and Raju will unmute you. And I would request you to offer any comment or question. And then I have a few specific issues to bring up. But first, your comments or questions, please. And thank you for listening. Moira, thank you for smiling.
Dr. Param?
Hello?
Yes, Dr.
Yes, Dr. Param.
Yeah, hi. Thank you, sir, for a wonderful talk. My question is, you already probably partially answered it regarding the legal aspects of this. And we have people committee in our own hospital trying to, make those criteria if we come, push comes to shove, who to give ventilators and not. So is it something in the offing to support those things like criteria for extreme age or something? Is somebody working with the government or something so that we have something concrete we can put down on regarding those criteria?
Dr. Param, I am glad you are here in this group because so many issues you have already thought about deeply. In answer to your question, yes, the Supreme Court procedure of 2018, though it accepted advanced directives and termination of artificial life support as necessary, put in a complicated, impractical procedure. What can be done about it? A lot can be done about it. Now, certainly our organization is also working on it, and we'll get your input all. That is to be done within the next couple of days or so, I fear. There are two courses of action that is possible. One is for the government to bring out an ordinance, because the Supreme Court said the Supreme Court judgment will be valid till there is legislation on the matter. So that means unless there is a law, or in this case, and there is no time, an ordinance, the Supreme Court law will remain valid. The difficulty is that today, so far, the immediate future is talked about. Tomorrow and day after are talked about. The problems following the withdrawal of lockdown on the 15th is talked about. But we are not talking about the social impact and the numbers at the end of the month. This is something that we need to do. One of the outcomes of this workshop, that this series that I hope will cause, is not only our ability to deal with these issues, but also we all giving greater awareness to it. Let us hope we will work on it. We are working on it. I'm sure many others are working on it. I will present this to PalliCovid Kerala also, friends. But once we have some clarity about the steps, but even today, much of my time was taken up with the thoughts about this. There are two possible courses of action. Neither seems easy. One is for the Supreme Court to review its judgment and put in an interim judgment for this crisis. The second is for the central government to bring out an ordinance, or even a state government to create something so that the others may decide to follow it.
Sure.
Not easy, but we'll try. Something is not easy is not a reason for not trying. We will try.
I understand. Only just a small quip that the Supreme Court, I think, mainly deals with withdrawal of care. Here we're talking about something different, giving a ventilator or not. I think this will have to be incorporated into that. Yeah, because I don't think we dealt, this situation was never there, whether to give a ventilator or not. And rather than withdrawal of support is what they mostly dealt with.
Dr. Param, in the Supreme Court judgment, also has one sentence saying that even when there is no advance directive, or when it's a question of withholding, the same procedure will apply. So if you are going the legal route, again it will be the complicated Supreme Court route. But the Indian Council of Medical Research did a series of meetings on the Supreme Court verdict and its impact. And legal experts say that all the issues related to the Supreme Court verdict become valid only when there is a conflict of opinion. They repeat that the doctor's duty of care is paramount. If the doctor is clear about what should be done, then this is not appropriate, the ventilation is not appropriate. And if the family agrees, if the family is in conflict, it's a problem. Or if the patient is competent, the patient agrees, and that's documented. The lawyers seem to feel that the Supreme Court judgment doesn't come into play at all. They say it becomes a valid issue only if there's a conflict. But this is also open to challenge.
Thank you, sir.
Thank you, Dr. Param.
Dr. Mara?
I was just following up from that really good discussion on the not so much the legal basis. There has been some work by the Kerala group looking at algorithms to support decision making and heavily looking at experience from elsewhere. So there may well be some help for the algorithms that doesn't take away the legal issue that you've talked about, but may well support decision making.
Thank you, Moira. Yes.
And Dr. Shobha has commented that if there is a shortage of ventilators, the ethical principle of justice come into play. It will be difficult to choose though.
Sorry, who is the question from?
No, Dr. Shobha's comment.
Shobha, I totally agree. How can a doctor sitting there, overworked, heavily burdened, emotionally charged doctor, decide, okay, one ventilator? No, I will give it to you. It's so impossible, and that's why this formation of ethics committees in hospitals, not the IRBs that are concerned with only research. They cannot handle this, but at least a 3-member committee of, if there is an ethicist in the group, yes, but also palliative person, clinician, other clinicians, somebody with the management, somebody in the management, together having to take that tough decision. It is tough, but it's going to be on us. It's going to be on us by the end of the month. And what will we do if we do not think about it now? Yes, the triage, Shobha has also commented, extremely difficult. That's why we have suggested triage for decision making in the guidelines. Absolutely, absolutely, absolutely. The triage person is important. But even afterwards, you will still have many issues. 2 young people, both have very promising life together. And how will you choose? And that's where an independent committee, not leaving the responsibility to one clinician, becomes important. Somebody other than the treating team that I can refer to. Hey, I don't know what to do, man. Please do help us. Seema has commented by chat, ratified by someone not involved in the care of the patient. Absolutely, Seema. End of life care ethics committee. Seema says they do that at Manipal. Good for you, Seema, and well done, Manipal. Withholding as well as withdrawing. Absolutely.
Dr. Shobha?
Yeah, I think are we going through the guidelines for ethical issues? We had prepared one in which we were saying that okay, we'll have a triad system where other people will make a decision whether there's any need for this person to go on a ventilator or not. So that's a decision making on a ventilator. But like Sir said, who will go on the ventilator is a very tough decision. But if again, what is happening in Western countries is people with a lot of comorbidities, they are not even being looked at, which is a sad situation. Or people above a certain age, they're not being looked at because of lack of ventilators. But again, if a scenario is present to us with young people, same age with no comorbidities, we have only one ventilator, who do we choose? It's $1 million question. Whether we, of course, like Sir said, we have to kind of try, give it to a triage person or a team, or make innovations like connecting with one ventilator to 2 people. I don't know, I'm just saying, because that's what we've seen. There are a lot of adaptations being done to ventilators, a lot of ventilators being made by different companies and things like that. So any thoughts on that?
Shobha, that's a long question, and part of the answer that was already answered. Part of the question was already answered. Yes, it's going to be difficult. Now, if I know, I mean, as an you and I both have handled people on ventilator. Artificial ventilation is not a question of just mechanically pushing some air into the lungs. And one of the devices that I saw, I mean, not only a picture, is actually an ambu bag and 2 things coming and pressing the ambu bag so that some air goes into the lungs. Nobody can survive on that long enough. The sophisticated ventilators have a flow system that's as much in alignment as the normal airflow as possible. Because if you push a large amount of air in, the larger alveoli open up, the proximal alveoli open up, the distal and smaller alveoli gradually keep on collapsing. And in a few hours, you have a patient with pneumonia on your hands. So it is not as simple. These innovations are great for the future, But I really do not think, as an intensivist, I really do not think it is that simple. There was something else about the Shobha. You mentioned triage to decide who goes on the ventilator. But the horror stories that we hear from Europe is that actually elderly people still alive were
Okay, I think we lost Sir. In the meantime, Seema was asking about the survival rate who require ventilation in COVID. So in the PalliCovid group, we had a discussion, and we found that that's very low. Only about approximately 5% of patients, isn't it?
Dr. Charu?
Yeah, can I take that question?
Yes, yes.
There are very conflicting reports which are coming from various parts of the world. The first report that I saw said that 97% of patients who required mechanical ventilation would end up dying. But other information that has come on later on is that only about 50% patients would be dying. So I think it's not just a question of which ventilator and at what time to institute the ventilator. It also matters on what is the team capable of doing, the intensivist, the pulmonologist, because such vast differences in the percentages of people who are likely to die on a ventilator cannot be explained in any which way. Your thoughts?
Okay, thank you, Charu.
I think there is a thing about I mean, as you already mentioned, the stage. I'm not an expert on COVID, but the stage where, so if easy availability of ventilator, they put it early, possibly the chance of survival is good, but this is like impression I got. I'm not sure about the data behind it.
the first report of 3% survival after ventilation came from China, and I myself used to quote it. But as Charu says, more optimistic reports are coming in, and as Dr. Param very correctly said, it also depends on how it is done, by whom, and one of the laughable things that's being done, along with creation of mechanical devices for ventilation, is the thought that we can train a lot of doctors in critical care by online courses. And every intensivist in this group knows how technically challenging a job this is. And it's not a matter of giving a course. I think giving a online course on palliative care is about 153 times more effective than trying to teach with a short online course on critical care. That is so tough. There are several questions that had been asked. Rajeshri, you had a question which I cannot see now.
Sir, I don't know whether that was answered before because I lost connectivity in between. My question was, suppose the triage team finds that the patient is unlikely to survive after resuscitation, not resuscitation, ventilation and other supportive measures, but the patient, if he or she is in a position to respond, or if the family wants to institute ventilator or other life supportive measures, and here the family wants, but the triage team or the professional team doesn't recommend. So if a conflict comes like that,
Rajeshri, we do not have a clear answer to that, but a practical answer I'll come up with. Suppose there is no question of lack access to ventilators. There is no question of cost. We have plenty of doctors, we have plenty of ventilators in that dream-like heaven. We could offer, that person has a right to decide whether he should be offered that. Autonomy becomes the overriding principle. But in the real world, that's where we will need a committee, ethics committee, to balance between autonomy, beneficence, non-maleficence, and justice, and to arrive at a decision. That'll be a tough decision. Sunita, you mentioned that 97% mortality, but as you yourself point out, that was the first study, and that is, I don't think that's any longer valid. Moira totally agreed that it may also be the pre-COVID condition that is a determinant among many others. And early ventilation is showing a good prognosis. This is not only COVID. For any patient, if there is ventilatory failure, the longer you delay it, the more systems get involved. And as soon as the respiratory failure is apparent, the patient has to go on ventilator, no argument about it. And Moira adds, Moira, you mentioned the experience with triage, not only in COVID. Would you like to speak out?
I was just going to point out that in those countries, it's normal, and I know it is in India, to actually use functional status pre and also the chance of recovery as an admission criteria. So it's not a case that anyone who wants ventilation would automatically get it. It would be balanced out with the ethical discussions we're having now in both the UK and Germany.
Thank you, Mara. Sunil, how do you want to handle this? I see that we have only 4 minutes left. Many people have not spoken yet at all, but I want to reassure everybody. Today is only the opening session. We are going to have 5 sessions more on individual matters like individual symptoms and communication issues and end-of-life care. But let me just make one point about several questions that would be valid for several questions that came up here. You talked about the family not agreeing for withdrawal of ventilation or withholding of ventilation. The point is, the counseling has to start early. If as the patient is in a calamity or near calamity already, you go and try to talk to the family, their responsibility, what do you mean? My father is important, save him. That's a natural emotional response, which is why discussion about prognosis and helping the person to ventilate feelings is important. And you, the busy clinician, will not have enough time on it. But if you spend 5 minutes with your medical social worker or counselor, who will then take the larger role, then maybe you can go back and spend 2 more minutes to clarify facts. The early discussion is vitally important, not a head popping out of the intensive care room and saying, hey, you have a choice, this or this. That's unfair. Sunil, I have had my say. We have only 3 minutes left. Over to you.
Dr. Chitra?
Am I okay? No, so I just wanted to go back to the question that I asked before, because I thought we are actually working on some guidelines, as you know, for this probably this explosion or crisis which is going to come, and we are going to face a lot of people in non-palliative care settings or settings which will not have ethics committee, or there will be only some institutions which have this across India and in Kerala. So will the recommendation that there should be an ethics committee be feasible for all settings?
Sunil, can I answer that?
Yes, yes.
It will be feasible only if there is a government directive. If we are able to persuade a state government to accept it. Then central government decisions will be easier. Getting our voice heard by the central government in a country with 1.39 billion people is not easy. But one state government's decision generally tends to be looked up to. This is an important part in strategy, is my feeling.
Exactly, sir. I mean, that's exactly what I wanted to say, that probably what we need to highlight is what palliative care can do in these situations. We are talking about challenges, but what can we actually offer during these situations?
Thank you, madam. Dr. Chandni says we don't even speak the basic issues with relatives, and the clinicians very much stressed and don't have the help of a social worker.
Dr. Chandni, very true. Maybe that scheme that we are making, including we are requesting triage, maybe this just a recognition that this is necessary, and a few weeks which we may get for training may solve part of the problem. The problem is going to be there and cannot be wiped out completely, but at least a partial solution is something we can attempt.
Okay. Before ending this session, are there anybody in this group who is working with COVID patients right now?
We are in the backup team. So neurologists are at the backup to be called when required. So we made different teams, and as Dr. Rajagopal very rightly said, that is going to be an issue also, that the intensivists are the right people. And when it goes back to the clinicians and non-clinicians, we don't know what's going to happen with managing the ventilators. So we have made the teams. We don't know how it will pan out if the catastrophe comes.
Dr. Murthy?
Sir, basically, we are not at all prepared for this emergency. We do not have masks. We do not have uniforms. We do not have hospital beds. Leave alone thinking of ventilators. The number of ventilators which work and people trained to intubate are also not available. This is a great problem. It will take a long time. There are surgeons and there are anesthetists who are wearing the same uniform. They're not getting another Jamaat uniforms. So we have lots of problems. In the beginning, very joining them itself, talking to them itself, and the number of people that are coming who deserve admission, who don't have beds. Now they are now preparing, but good equipment is not that easy to come. We cannot get once all of a sudden you order and get 1 lakh into the ventilators. It's not like that. It will take time. It will take
absolutely
time. In the meanwhile, a
absolutely
lot of people will suffer.
Absolutely, I agree. Sunil and Raju, we have a commitment also to end on time. We must realize that we are having a very, very busy group of people together. So Raju, will you please make sure that there are a lot of questions and comments in the chat? Will you please make sure that they are documented so that we'll be able to address it in the next session or even by email to everybody? I really think, considering that it's already 3 minutes past time, we have to wind up today, and we'll continue this discussion on the ensuing.
Our time actually ends at 4 p.m. So now we passed 3 minutes. So we have to end the session. So we were discussing the elements of suffering and what is the relevance of palliative care in COVID-19 or in any other chronic disease situation. And there were a lot of discussion on the ethics and ventilator mortality, etc. And there were many questions to be answered, which we will send you in a couple of days. Thank you all for your active participation. We'll see you tomorrow.
Thank you all. We can see the continuation of class as Principles of Symptom Management tomorrow at 3 o'clock. Till then, bye. Thank you.